We're going to do the first part, the first half roughly, of the cardiovascular system PowerPoint this morning. And Pansy Amsterdog is all ready. She's tanked up. She got some fluids and had her breakfast and is very excited to be part of this whole process. We're breaking the cardiovascular system into two camtasias because of the length of this material. It's a long PowerPoint. It's pretty close to 2 times as long as most of them. This is not really that surprising since the cardiovascular system is extremely complicated. It is also obviously extremely important for our survival. So let's go. Okay, so there are going to be 3 components to have a cardiovascular system. One would be the heart. Pansy knows the next one, right? Blood vessels, and last would be blood. Okay. There are actually 2 systems, or it has 2 subdivisions, I guess perhaps you'd say. One of the subdivisions carries blood to the lungs, that would be the pulmonary system, and the other carries blood out into the remainder of the body. We'll talk about functions next. There are a number of functions. One of the important things of a 4-chambered heart, and we should begin with the understanding that not all vertebrates have 4-chambered hearts. In fact, that's a fairly, in terms of evolution, a fairly recent development. Fish, for example, have 2-chambered hearts. But the 4-chambered heart allows us to keep oxygenated and deoxygenated blood separate. That increases our efficiency of delivering carbon dioxide to the lungs to get rid of it, and it also increases the efficiency of getting oxygen out to the tissues. It also is important to keep blood flowing in one direction, and in fact in some of the places we'll see there are semilunar valves which prevent backflow of blood. It creates blood pressure to move the blood. In order to have the fluid move through the vessels, there has to be a pressure gradient. That is, that in one place the pressure has to be higher, and in another place the pressure has to be lower. It supplies blood based on needs to the body. So what this is basically saying is that we're not just sending all the blood out in all vessels equally all the time. That the blood is actually directed specifically to increase flow to areas that really need the exchange with the blood, and decrease flow to areas that are not in as much need. We have to do this because we don't have an infinite amount of capacity to get blood circulated through the body. There also is an endocrine capacity, specifically within the heart, and the atrial natriuretic hormone ANH is produced by the atria, and this helps adjust blood pressure. So the anatomy of the heart. The heart is located in the thoracic cavity, and there's actually a subcavity within the thoracic cavity that the heart is within, the mediastinal cavity. We have 2 pulmonary cavities, we have 2 pleural cavities, and we have 1 mediastinal cavity in the center. The mediastinal cavity is sort of shaped like a cylinder, and the heart doesn't occupy the whole mediastinal or entire mediastinal cavity. It actually is only going to be part of the inferior mediastinum. It's covered by a pericardium. We'll talk more about that. And the heart is rotated toward the left, so the right side of the heart ends up being a little bit anterior, left side tends to be a little bit posterior. The apex is tilted anteriorly, and the apex is the pointy end of the heart, which is at the inferior end, and it goes anteriorly, and then it is also tilted to the left. So it's sort of arranged obliquely within the thoracic cavity. Endocardium is a covering inside of the chambers. This is a single layer of simple squamous epithelial cells, and it continues out into the blood vessels, both the veins and the arteries that are connected to the heart. The endocardium is very smooth, and the advantage of having smooth surfaces is that it reduces the risk of abnormal clot formation. Okay, we have the myocardium. Myocardium is the muscular layer. This is made up of cardiac muscle tissue. We talked about cardiac muscle tissue back in the topic dealing with different types of muscle tissue. Remember, there were 3 kinds: skeletal, cardiac, and smooth. It is the thickest of the three layers. And then we have the epicardium. And there's a visceral serous epicardium that folds back over the heart and creates a serous fluid, hence the name serous pericardium. And there are two layers of the pericardium. There's a deep layer and a superficial layer. And the superficial layer is fibrous. The deep layer is the serous portion. Remember that epithelial cells are typically involved in secretion, and this is one of those cases. So the pericardial fluid helps do a couple of things. One is it lubricates the heart, and you might think, well, it's not going anywhere. Well, it does move, and so it rubs against the adjacent tissues, and that pericardial fluid prevents abrasion of the tissues. It also, as we've seen before, serves to dissipate heat. Remember that water has a very high specific heat, and so it can receive quite a bit of energy without increasing its temperature dramatically. Then the parietal pericardium is going to be fused to the outermost fibrous pericardium. The fibrous pericardium is sort of an unusual part of the coverings in the thoracic cavity, in that most of the pleura, for example, are all epithelial tissue, but the fibrous pericardium is more like connective tissue, and it's strong. So the fibrous pericardium is going to have a couple of functions. It's going to anchor the heart to the blood vessels and also to the diaphragm, and that prevents the heart from flopping around when you change the position of the body. Fibrous pericardium also helps contain the volume of the heart and reduce the likelihood that it would overfill. Excuse me. Occasionally the coverings become inflamed, and if we have the pericardium inflamed, it's called pericarditis, and endocarditis is an inflammation of the endocardium. Those would be abnormal conditions, obviously. Heart's going to have 4 chambers. As I said, not all vertebrates have that. That's a fairly recent evolutionary advantage, adaptation, change. And the 2 superior chambers are called atria. They are receiving chambers. They have thinner walls than the ventricles. This thin wall is form fits function, right? So thin walls indicate that these don't do a lot of pumping. They do a little bit of pumping, but not a lot. Mostly receive blood. Another name for the atria, auricle. Auricle is means little ear, and it's sort of an external flap. So we use the atria, the word atrium and the word auricle interchangeably. An atrium is actually the chamber inside, and the auricle is the little flap on the outside. The cells in the auricle produce the atrial natriuretic hormone, ANH, and that affects the heart's behavior. Okay. Auricles have cardiac stem cells, so they have the potential to replace cells and mature and differentiate. But there's a limited amount of that, so if you damage your heart, it doesn't just completely recover automatically and everything is great. There is a limitation to how much recovery you can get. The atria are going to be separated by the interatrial septum. And then inferiorly we have the 2 ventricles. The ventricles are pumping chambers, so because they're doing this form fits function, they have thicker walls. The thicker walls are thicker because there's more of the muscle tissue that is able to create the pressure to pump the blood. If we examine the 2 ventricles, we find that the left ventricular wall is thicker than the right ventricular wall, and this reflects the fact that the left ventricular wall actually creates more pressure. It has to pump harder. However, it's really important to note that they both pump the same volume, even though one is pumping harder. The reason the left ventricle has to pump harder to be effective is that there's more resistance in the systemic circulation than there is in the pulmonary. And so without the extra pressure, the blood wouldn't move through that system. So here is a picture that was drawn by a former student of mine, Laura Holder. And Laura was very generous in helping prepare a variety of pictures for the class while she was taking the class. And we do a transection here. We see that the shape of these two ventricles is much different. The right ventricle has a kind of a crescent shape, and the left ventricle is more cylindrical. And so at first inspection, you might think, well, those are different volumes then. Actually, they're not. Actually, they're the same volume. And the reason the right ventricular wall gets deformed so much is because the left is so thick that it's very difficult to change its shape. So it assumes a minimum amount of stress by creating a circular cross-section, whereas the right sort of gets pulled around the left because it's thinner and more easily deformed. Okay. So ventricles are separated by a septum, the interventricular septum, and not surprisingly, that septum is pretty much the same thickness as the left ventricular wall. And this is reasonable because it is part of the left ventricular wall. The right atrium. Right atrium is going to come into, we're now going to kind of follow a drop of blood through the heart. You'll find on the website that there's a tutorial, actually two tutorials. One is a description of the flow of blood through the heart, and naming all of the structures in the order that they are encountered. The second one is a drag and drop exercise. It was created with software that Mac computers don't support. So if you have a Mac computer, it probably won't work. But if you have a Dell or some other PC that's more of an IBM clone, you'll probably find that you'll be able to use that to help study for the exam. I strongly recommend that you learn that path of blood and all of the things that are encountered. But we start with the right atrium. Blood is going to enter the right atrium from three structures. So Pansy knows what they are. Right, the superior vena cava. Whoop, there it is right there. And right, the coronary sinus, it's right there. Coronary sinus is actually not a vein. And then the right, the inferior vena cava. Oh my goodness, she's so good at this. Now notice, Pansy, we have blue arrows here. So blue arrows indicate what? Do you know? Right, oxygen deficient blood. She is so wicked smart, it's just unbelievable. Also, Laura Holder redrew this picture for the class, and you see that the right ventricular wall is thinner than the left. And also I asked her to draw it so that the two volumes would look pretty much comparable, which is great. The one deficiency of this picture, and I didn't have the heart, if you'll pardon the pun, to ask her to do it over, was that the right atrial wall is about the same thickness as the right ventricular wall. That is not accurate. So the right ventricular wall is thicker than the right atrial wall, and also thicker than the left atrial wall. The left ventricular wall is thicker than the right. The coronary sinus has a structure not unlike a Quonset hut. And a Quonset hut, Quonset huts were designed during the Second World War to meet a need to be able to put up inexpensive housing quickly without a lot of resources and effort. And one of the things they did was they saved by not installing a floor. So a Quonset hut would be installed wherever there was a floor already. In this case, the grass is the floor. So in the heart, Quonset hut sits like this roof or dome over the coronary sulcus, and the coronary sulcus is the floor. Well, at least the part of the coronary sulcus. Okay, it doesn't go all the way around the heart. So blood is going to come in to the right ventricle from the right atrium. In order to do that, it has to pass over a valve, and the valve would be right, tricuspid. Tricuspid valve is going to have how many cusps? 3. See, she's looking at me like I'm an idiot, that I'm asking her really dumb questions. But you have to keep not all challenges are extraordinary. So a tricuspid valve is going to have 3 cusps. There's the tricuspid valve right there. And although they're not shown in this picture, the tricuspid valve, all the 3 cusps are going to be attached to the ventricular wall by chordae tendineae. And the chordae tendineae we'll talk about here real soon. Here's a statement noting about the thickness of the walls. And again, Laura did a nice job and was very helpful in doing that for us. So the right ventricle. Has the in general, the atrioventricular valves, sometimes known as the AV valves, look like trampolines. I'm sure most of you have seen those. And trampolines do have these springs that go to the frame. So the the tricuspid valve does not have springs, but it does have chordae tendineae, tendinous cords, and these are going to attach one end to the edge of the valve and the other end to the papillary muscles, which we'll talk about in a moment. Some of you have probably heard literary or read literary descriptions of somebody pulling on someone's heartstrings, or maybe you've heard that in a song. The heartstrings literally are the chordae tendineae. So usually people don't pull on those because you'd have to get inside the heart, and that would usually have a bad outcome for the person that you were taking their heart apart. As I mentioned, the other end of the chordae tendineae do attach to something on the walls. They are the papillary muscles, and the papillary muscles look like pimples. Although honestly, if you have pimples that look like the papillary muscles, you should go see a doctor because they're kind of nasty. And the papillary muscles are functionally pretty important. Now, here is kind of just an aside, but it's an important one. Smooth muscle and cardiac muscle respond to being stretched by contracting against the stretch. This is an automatic response to the stretching process. And the advantage of that is that it prevents the structures they're part of from overstretching and rupturing. And we know that smooth muscle and cardiac muscle, at least in many cases for the smooth muscle, are forming tubular structures, and so there isn't any joint as there would be with skeletal muscle to prevent overdistension or overstretching. So these are really a way when the papillary muscles sense their cardiac muscle tissue, when they get pulled by the chordae tendineae as the valve shuts, it stretches the papillary muscle. Papillary muscle responds by contracting against the stretch, and it pulls on the chordae tendineae and helps prevent those valves from prolapsing back into the atrial chambers, both on the right and the left side. There are papillary muscles on both sides. Okay. Sometimes people think, oh, well, they got these cords attached to the valves, they must pull the valve open and they must pull the valve closed. That is not the case. The chordae tendineae do not open valves, they do not close valves. They just prevent the valve from going too far. Semilunar valves kind of look like shirt pockets. They don't have any chordae tendineae. They work, and there are usually 3 of these cusps for an individual semilunar valve. Okay. So I think we've talked about this actually in the semilunar valves. They're found in 2 places in the heart, but they're also found in the lymphatic system, the lymphatic vessels, and also in the veins. Okay. So they're sort of shaped like shirt pockets. I like this analogy. It's one that I came up independently with. Somebody else may have thought of this too. But they not only look like shirt pockets, they're even functionally similar. So if you have a shirt pocket and you take your hand and run over the surface of the shirt pocket away from the direction that it opens, it just goes up against the shirt. But if you back up and you come toward the shirt pocket would deploy almost like a little parachute. So the valve is going to push these valves open, and it also pushes them closed. And as I mentioned, semilunar valves have 3 cusps. Okay. Blood is going to go from the right ventricle into the pulmonary trunk once the pulmonary semilunar valve is open, and again gets ejected from the heart. It's important to note that all these valves are going to open and close passively, and so what that means is there are no muscles that pull them open and there are no muscles that pull them closed. So here the tricuspid valve shuts first, and the pulmonary semilunar valve gets pushed open, and the blood gets ejected into the pulmonary trunk. The pulmonary trunk can have a couple of different names. Sometimes people call it the pulmonary aorta. Sometimes people call it just a pulmonary artery. I think pulmonary trunk actually is the best name for it. It's kind of a unique name, and there is another aorta, and there are other pulmonary arteries. So I think pulmonary trunk is kind of a good name. Trunk is usually reserved for vessels that eventually are going to become more than one, or form from more than one vessel. From the pulmonary trunk, the blood is going to go into the right and the left pulmonary arteries, and then it's going to get distributed out into through pulmonary arterioles and eventually pulmonary capillaries. Pulmonary capillaries surround the alveoli. They're in very close association with the epithelial cells of the alveoli, and this is going to facilitate the exchange of the respiratory gases through the process of diffusion. We'll talk more about that when we get to respiration. Okay, once we get to the lungs, blood in the lungs is going to pick up oxygen. It's going to lose carbon dioxide. This probably seems like a curious sort of situation. The reason that the carbon dioxide goes one way and the oxygen diffuses in the opposite way is all because of the concentration gradients. Okay, and pulmonary capillaries are then going to drain into the pulmonary venules, which then eventually drain into pulmonary veins. There are 4 pulmonary veins, 2 from each side, and they come back to the left atrium. And if you look right here, you can see there are 4 openings, right? So here are the 2 right pulmonary veins, and here are the 2 left pulmonary veins. This is the left atrium. Now you notice that the arrow color is shifted. We've gone from blue to red, and the red indicates that the oxygen levels are high. Okay, so blood now is going to be in the left atrium from those 4 pulmonary veins. It's going to go into the left ventricle from the left atrium, and in order to do that, it goes over a valve. That valve is called a bicuspid valve or the mitral valve. And bicuspid means it has how many cusps, Pans? 2. She's rolling her eyes again. Mitral refers to the angular shape of the valve. And some of you may have heard of a miter box. A miter box is a device used by carpenters to cut angles in wood. Or some of you may be somewhat religious, and you may have heard of the bishop's mitre. The bishop's mitre is an angular hat that the bishop wears on his head, and when he does, it makes him look like a cone head. Okay, so there's the bicuspid or mitral valve. Now I'm going to show you a picture that the person whose picture it is of doesn't know that I have this. I am hoping that you will not share this with that person should you encounter that person, because I'm pretty sure that this person will be very annoyed with me having shared this personal photo. He's rather self-conscious about this, but maybe some of you know that the former Bishop of Rhode Island was actually a conehead, and here's his picture. Oh my God, this is an accurate photograph taken by a stealth camera placed outside of his home, looking in through the window. You can see how he has a cone head, and you can see he had the cone head hat, right? That's the mitre. He has cone head lights, right? And this is he's watching a TV. And Pansy, what is this? Do you know? Right, rabbit ears. A lot of students are not familiar with rabbit ears, but if you have low-tech TV, sometimes you use rabbit ears as an antenna. Oh my God! Please don't tell him I have that picture. Okay, so now the blood is in the left ventricle. Blood is going to enter the aorta from the left ventricle. In order to do that, it has to go over the aortic semilunar valve. So as the left ventricle contracts, it pressurizes the blood. The blood pushes the bicuspid valve closed first, and then eventually, when the pressure is great enough, it pushes the aortic semilunar valve open. So bicuspid closes first, then the aortic semilunar valve opens. This would be where the aortic semilunar valve would be. Okay, and then the blood goes into the aorta. And again, notice red arrows indicating oxygen-rich blood. So blood is going to go out into the branches of the aorta. it's going to get distributed into the systemic circulatory system. So the third branch of the aorta is the brachiocephalic artery, and there's only one of those. There's not a right nor a left, just one. And then here we see the aorta, which is passed on the other side of the heart and descends down toward the abdomen. And eventually it goes through the diaphragm at the level of T12 body, interestingly enough. Goes through the diaphragm and into the abdomen. The fourth branch is the left common carotid, and the fifth branch is the left subclavian. So some of you are probably saying, okay, we did the third, the fourth, and the fifth. Where's the first and the second? Where are they? The first and second branches. Can't see them in this picture, but they're right at the base of the aorta, right in this region, and those would be the coronary arteries. Okay. So, the aorta. The aorta is going to have the first branches, coronary arteries. I just mentioned that. Coronary arteries carry blood to the walls of the heart. The remaining blood then goes out into the other branches of the aorta. So, one of the things that is used to determine the heart health and the situation the heart has is the sounds that are made. And so a lot of people think they know what causes these sounds. First of all, does anybody know what the heart sounds are? Pansy knows. Right, love dub. She has kind of a funny accent, but that's what she was saying. Remember that the papillary muscles and the chordae tendineae are going to prevent their valves from closing. And when the ventricles contract, they push the semilunar valves open, and before they do that, they actually push the atrioventricular valves close. Okay, so this is kind of an important part right here. So kind of pay attention, see if you can follow the logic here. When the blood ejects into the arteries stretch, and the reason they stretch is because the heart is creating a lot of pressure, much more pressure than the arteries can generate, because the arteries have thinner walls than the heart walls themselves, the ventricular walls. And because the arterial walls are made of smooth muscle, we talked about this just a little bit ago, when they get stretched, they contract against the stretch. They're not strong enough to get back to their original position, so they remain stretched, and they remain with sort of a tonic contraction against the blood. As soon as the heart relaxes, the ventricles relax, the arteries are still squeezing, and so the blood starts to leave the arteries, and some of it goes backward toward the heart, and when it does, it closes the semilunar valves that were just open a moment ago. The sounds are lub-dub, and these are the sounds created by the valves. The lub is the AV valve closing, and the dub is the semilunar valves closing. And a lot of students say, when asked, what causes these sounds, the students say, the opening and closing of the valves. If you have normal valves, the opening doesn't make any sound, only the closing. And in fact, the only part of the closing that makes sound is when the valves completely close and slam shut and vibrate. You can demonstrate this for yourself with a door. If you get a door that doesn't have any kind of automatic return, you can swing the door open, it shouldn't make noise, and you can swing the door closed, and it won't make noise until it hits the door jamb. This is an experiment I usually perform if there's a door handy where I'm teaching this class. Okay, sometimes people have abnormal heart sounds. These are called heart murmurs, and they usually indicate that the valves are leaking when they're closed, or that they don't open all the way when they're supposed to. And there are basically two causes for heart murmurs. One would be that a person has a disease, for example, rheumatic fever. The bacteria responsible for that disease damage the heart valves. Valves are more easily damaged than other tissues because they're connective tissue. They don't have a really good blood supply and a good immune response into the valve itself. And so you get scarring a lot of times. The other time that people get heart murmurs can be if they have a birth defect. This is not unusual. And in fact, I have a heart murmur that was due to a birth defect. Some of you probably think I have more than just defects in terms of my heart. That could be. Okay, now coronary circulation, special kind of circulation. The heart tissue is going to need its own blood supply. The cells are working really hard, especially in the ventricles, and if they weren't getting their own circulation, they would fatigue quickly because materials couldn't diffuse in or out of the tissues quickly enough to meet their needs. So the coronary arteries and the coronary arterioles bring blood to the coronary capillaries, and those coronary capillaries then are going to have exchange with the tissues of the heart wall. And then the coronary capillaries drain into the coronary venules and veins, and the veins eventually drain to the coronary sinus. Coronary sinus is not a vein. Remember, we talked about it. That's the one that looks like a Quonset hut. And that brings oxygen deficient blood back to the right atrium. You might be thinking, well, why is this blood oxygen deficient? It came from the aorta. It did come from the aorta, but while it was in the cardiac tissue, the oxygen was diffusing out of the blood and into the cardiac tissue because cardiac tissues had used so much oxygen up. Okay, we'll talk a little bit about the physiology of the heart. We did the anatomy now. There's a conduction system of the heart that helps spread impulses throughout the heart so that the cells in any one chamber can all contract at the same time. This is beneficial if it happens because it means that the heart is much more efficient as a pump. It's an intrinsic system. It doesn't require external nerves. And as I mentioned, the atria are going to contract at the same time. They usually contract first. This is if we have a normal cardiac activity. There's a slight delay, and then the ventricles contract. And they contract at the same time. And this efficiency is increased if we have this delay between atrial and ventricular contraction because it allows the atria to empty more of their blood into the ventricle before the ventricle starts to contract. Remember that when the ventricles contract, they close those AV valves and no blood can come in from the atrium during ventricular contraction. Can't come into the ventricles. Okay, if there were no coordination between the atria and the ventricles, they would contract at different rates, and this would decrease the efficiency of the heart. The atria would contract at a higher rate, and so they would be contracting at various times relative to the ventricular contraction, and that would mean that they would become less efficient in delivering blood to the ventricles. Most of the delivery of blood to the ventricles goes passively by just having the blood flow in before the atrium contracts, but it is supplemented by the atrial contraction. So there are two areas within the heart that have nodal tissue. Some of you probably know that. And the nodal tissue is going to undergo self-excitation. You might even know somebody like that. One of them is the sinoatrial node, or SA node. And the SA node is going to be posterior superior wall of the right atrium. Then the second node is going to be the AV node, or atrioventricular node. That's going to be at the base of the right atrium near the interatrial septum. Okay, so the nodal tissue is kind of curious in its attributes. It has both muscular and nervous characteristics. And so under normal circumstances, the sinoatrial node, or SA node, is going to initiate the heartbeat. And the reason it does this is because the cells of the SA node are the first cells within the heart to depolarize and have an action potential. And they spontaneously depolarize. It doesn't require outside interference or stimulation. The SA node does this all by itself. You could take the heart out of a person and it would continue to beat for a while. Anyway, the signal from the SA node is going to spread throughout both atria, and because of this spreading, it turns out that basically both atria contract at the same time. Again, this is if we have normal situations here, and that increases the efficiency of the pumping that they do. Remember that we referred to the atria as receiving chambers, but they do a little bit of pumping. Usually about 20 to 25% of the blood that goes into the ventricle comes in because of the atrial contraction. The signal spreads from the atria toward the ventricles, and it's going to reach the AV node, atrioventricular node. As I mentioned, there's a delay, and this delay is important functionally because it allows the atria to empty their contents into the ventricle before the ventricle contracts. Okay. The signal goes from the AV node down into two branches of the atrioventricular bundle, or AV bundle. And then sometimes this AV bundle is referred to as the bundle of His. It sends a signal into these fibers called Purkinje fibers, which are smaller in diameter but spread throughout the ventricular wall to help coordinate and synchronize the contraction of the ventricular cells. And again, those ventricular cells are going to contract after the atria have already contracted and are starting to relax. The signal also spreads from cell to cell within the heart because of what are called gap junctions. And these gap junctions allow the cells of the heart basically to act as a syncytium, meaning they all contract at the same time. Now sometimes there can be a situation where the SA node doesn't work. It could be a normal situation, like strong parasympathetic stimulation will cause the SA node to shut down. But it could be other things as well. If the SA node fails, then the AV bundle becomes the pacemaker of the heart, and it contracts at a slower rate. Now this shouldn't be really too surprising, since the normal rate is established by the most rapidly depolarizing cells, and those are in the SA node. If the AV bundle normally were to depolarize more quickly, then it would become the pacemaker for the heart all the time, and the heart would be contracting out of sequence. Now the one thing, because it's depolarizing at a slower rate spontaneously, that means that the heart rate is going to drop. So if you have a normal heart rate of 70 to 72 beats per minute, and you have this situation which is called a heart block occurring, then the heart rate will drop down to about 50 to 55 beats per minute. This is enough to keep you alive. I mean, you're not going to die from this change. Okay. Occasionally we get what is called an ectopic focus. An ectopic focus is an area within the heart that starts depolarizing more quickly than the SA node, and because it has the first cells to depolarize, it sets the rate, and depending on where it is, this pacemaker may reduce the efficiency of the heart. It can be because of mechanical stimulation of the heart, or electrical stimulation, or even chemical stimulation of the heart. One of the things that can do this in terms of chemicals would be caffeine or nicotine. Both of those drugs cause your heart to usually increase the rate of contraction, and it can be somewhat harmful because it's reducing the efficiency. Sometimes the conduction system fails altogether, not just for a short period of time, but for a long period of time. And this can be dealt with by having an electronic pacemaker installed. Okay. One of the things that doctors occasionally do are use electrocardiograms to monitor the electrical activity of the heart. And if you have some kind of irregular heartbeat. This is called an arrhythmia, and those, they usually try to deal with those because they're not beneficial. Okay, so let's talk about the cardiac cycle. Cardiac cycle is not made by Specialized or Trek or Giant or any of those bicycle companies. This is the series of events that occur between one heartbeat and the next. So the series of events that occur during one heartbeat. As I mentioned, the average rate is going to be about 70 to, some people would say 70 to 72 beats per minute. But it can be as low as 60 or as high as 100. And there are two phases of the contraction cycle, or the heartbeat, the cardiac cycle. The systolic phase, or systole, is the contraction phase where the cardiac muscle is contracting. And then diastole is the relaxation phase of the cardiac cycle. So we have several overall phases. We have phase 1. That means that's going to be the time when the atria are contracting. Normally it's about 0.15 seconds long. And normally both atria are in systole at the same time. Remember, during this phase 1, the atria are contracting but the ventricles are relaxed. And this allows the atria to pump blood into the ventricle. Okay. The higher pressure inside the atrium due to the systole results in the blood being forced in the ventricles. Now, I didn't mention this before, or maybe I did just briefly. About 75 to 80% of the blood that gets into the ventricles gets in there passively without any pumping at all. In this phase 1, you're getting that last 20 to 25% of the blood going in. In order to get into the ventricles, blood passes over the AV valve, or valves. This is going to be on both sides. And at this point in time, the semilunar valves are closed. And you might wonder, why are they closed? They're closed because of the last contraction. Remember that during the contraction phase of the ventricle, blood goes into the pulmonary trunk from the right side and the aorta from the left side, causes those walls to stretch. And then when the ventricle relaxes, those vessels start to go back toward their normal size by contracting, and they push blood back toward the heart, closing those semilunar valves, and they hold them closed until the pressure in the ventricle is high enough to blow them back open. That's why they're closed. So the ventricular pressure is going to start to build up, and eventually that pressure is going to be enough to close the AV valves, and that is called the lub of the lub-dub. Okay. Phase 2, the ventricle is going to start to contract now. It's normally about 0.3 seconds long, and it's called ventricular systole, and the atria are in diastole. So both ventricles are in systole at the same time, both atria relax in diastole. Pressure builds, and eventually the pressure is great enough to push the semilunar valves open. This is on both sides of the heart. The same thing is happening on the right and left ventricular side. The blood from the right ventricle is going to flow into the pulmonary trunk. Blood from the left ventricle is going to flow into the aorta. Both of those vessels are going to stretch because of the pressure, and then eventually the ventricles relax. And when they relax, remember the two vessels that receive the blood, the pulmonary trunk and the aorta, are contracting against the stretch. They push the blood back toward the heart and close those semilunar valves. But they also push the blood away from the heart. Okay, so as the vessels contract, blood leaves and goes out into the circulatory system, both pulmonary and the systemic systems. And so this contraction of the vessel walls is really important because it keeps blood moving all the time through the circulatory system instead of having intermittent flow as the ventricles relax. Okay, mentioned the blood flowing back toward the ventricles, closes the semilunar valves, and that is the dub sound in the heart sounds. Okay, phase 3 is going to be atrial and ventricular diastole. So here's the phase when both the atria and the ventricles are relaxed. It's about 0.4 seconds in duration, and all 4 chambers are in diastole, and blood starts to come back into the heart. It comes in from the superior vena cava, assuming you're standing up because of gravity, and it comes from the inferior vena cava because of the skeletal muscle pump. Okay, so the pressure at this point in all the chambers is low. Okay, so blood goes into the atria, comes in from the superior vena cava, inferior vena cava, and coronary sinus. Superior vena cava comes in because of gravity, inferior vena cava because of skeletal muscle pump. And the coronary sinus is just going to have blood oozing back into the heart from the coronary circulation. Okay, so blood is going to come into the left atrium from the 4 pulmonary veins, and then it's going to go passively from the atria into the ventricles over the AV valves, the tricuspid and the bicuspid valves. And semilunar valves at this point are closed, but both AV valves are open. Okay. So the next thing, we basically did that cardiac cycle. If I were you, I would study that for the first exam. I wouldn't be at all, or for this exam rather, not the first exam. But for this exam, I would not be at all surprised if you were to find an exercise on the exam that deals with blood flow through the heart. So the next thing we want to address is cardiac output. Cardiac output is the volume of blood that gets pumped in a minute. And it's going to be the volume leaving both ventricles. It's going to be the same for both the left and the right sides. And this is because it is a closed system. So since the right side is going to receive everything that the left side pumped, the right side pumps out and the left side receives that, and it has to be the same. The cardiac output is actually a function of heart rate and stroke volume. So here we have an equation. I know some of you are probably math challenged and are concerned about this, but it's not all that bad. So cardiac output is equal to heart rate, the number of beats per minute, times the amount of blood that gets pumped per contraction. That's the stroke volume. For an average person, it's about 4.25 liters per minute. That's pretty close to all the blood that an average person has in their circulatory system. So this is a pretty, and this is at rest. That's pretty impressive that your heart's doing all that work every minute of your life. Excuse me. We can have a dramatic increase in cardiac output up to 7 or 8 times the resting value during exercise. Obviously this is more work, and so there's a limit to how long this can be sustained, and if your heart isn't used to that kind of work, it could start to fatigue, which would be a bad thing. Okay, so let's talk a little bit about heart rate. The way we control our heart rate is through the cardioregulatory center. It's in the medulla oblongata at the base of the brain, and it's going to use autonomic nervous system primarily to control that heart rate. Parasympathetic stimulation will either slow or stop the heart. The reason it stops the heart is because the right vagus nerve, which is carrying parasympathetic fibers, goes directly into the SA node, and when it stimulates the SA node, it causes the SA node to stop having action potentials. The good news is that when you have your heart stop like that, it doesn't say stopped until you're dead. It usually will have a spontaneous contraction starting at a lower rate because of the AV bundle. Sympathetic stimulation is going to cause the heart to speed up. It also causes typically the heart to contract more strongly. Okay. And so the cardiovascular system has some baroreceptors, the aortic and the carotid baroreceptors. Most of you probably have seen news forecasts, including weather information, and they talk about something with baro in it. What would that be? Right, barometers. And barometers measure pressure. So the baroreceptors measure pressure in the aorta and the carotid arteries. If the pressure goes up, they cause the heart to slow down. If the pressure goes down, they cause the heart to speed up. So this is what happens. Pressure drops. Let's say that you sit up in the morning, and when you've been lying down in bed, and when you sit up, pressure drops. The baroreceptors monitor this drop, and in response they cause sympathetic signals to go out to the heart, which increases the heart rate. If the pressure goes up, it raises, then the signals are going to decrease the heart rate. I should mention that this baroreception can accommodate to chronic hypertension or hypotension. So this is a way of responding on a short-term basis, but the long-term, if you're chronically hypertensive or hypotensive, they stop being efficient and they sort of adjust to a new normal, which could be high or low, depending on what's going on. Okay, so the cardiovascular or the cardioregulatory center is going to be influenced by both the cerebrum and the hypothalamus. Another thing that happens is the adrenal medulla is going to release epinephrine and norepinephrine. These are stimulants for the heart, causing the heart rate to go up and the strength to increase as well. Okay. Some things that you can do to actually lower your heart rate include conscious meditation. If you meditate, it actually engages the vagus nerve. Vagus nerve, remember, is parasympathetic nerve fibers in it, and that causes the heart to slow down or stop. Okay, body temperature can affect the heart rate, so can electrolytes, and those effects are variable, so you don't really have to worry about a lot of detail on that right now. Stroke volume. Remember, the heart rate is one part of changing the cardiac output. The stroke volume is the other, how much blood is pumped per contraction. So the strength of the contraction is going to determine how much blood leaves. The stronger the contraction, the more blood that is ejected. Typically, parasympathetic stimulation reduces contraction strength, and sympathetic stimulation increases contraction strength. Okay. Some of the electrolytes that affect cardiac activity include, and this would be electrical cardiac or strength of contraction activity, includes sodium, potassium, and calcium. There is a very important automatic adjustment of output by the heart to how much blood is returning. This is described as by Frank Starling's law. You should be aware of this law. It is hugely important. So basically, the heart pumps out what it receives. If the heart receives a lot of blood, it pumps a lot of blood out. If it only receives a little bit of blood, it only releases a little bit of blood. And so this is a way of auto-regulating cardiac output. You might wonder, how could you affect that? Well, venous return is affected by physical activity, right? And the way it affects the output is if you have a lot of blood coming back from the veins, then the walls of the heart stretch. When the walls of the heart stretch, they contract more strongly and send that blood out. This is very, very cool. Whereas if you have a low venous return, the heart walls don't stretch much at all, and they don't send out very much blood. Okay. So when would this happen? Exercise. Okay, so when you're exercising, more blood comes back from your appendages. Why would that be? Right, the skeletal muscle pump. We talked about that before. This is such an important part of our cardiovascular activity. Also, we have the respiratory activity, the respiratory pump, pumping more blood back when you're breathing hard during activity. So the extra blood coming in is going to cause the atria to stretch. When they stretch, they contract more strongly, so they pump extra blood into the ventricles. When they do that, the ventricles stretch because they have more blood coming into them, and so they contract more strongly and they send more blood out. It is just like very cool the way this automatically happens. Okay. What if we have hemorrhaging? Hemorrhaging is an abnormal situation where you're losing blood. Obviously this means the venous return is going to drop, and if the venous return drops, then the heart will pump less strongly, and the outcome is obviously going to be the opposite that it was for exercise. You automatically adjust the amount of blood going out by having weaker contractions of the ventricles. There are ways of dealing with hemorrhage to prevent it from becoming detrimental to your well-being. It doesn't involve the heart directly. It involves activity out in the blood vessels and activity of our kidneys, which is a topic for another time. In order for the ventricles to eject blood into the arteries, the pressure in the ventricle has to be greater than the arterial pressure. If the arterial pressure is high, then the ventricle won't be able to empty itself. Okay, so a couple of things that can be sort of problematic in terms of blood pressure. Hypertension. Hypertension leads to high blood pressure, or is the name for high blood pressure. Arteriosclerosis causes high blood pressure. And typically if you have hypertension all the time, it reduces your cardiac efficiency because the blood can't be ejected out of the heart as well when the arterial pressures are high. Arteriosclerosis happens, the pressure goes up because the walls of the vessels become hardened and they're not as pliable and they don't stretch as well. So when blood is ejected into the vessels, they resist and less blood is ejected. Okay. There are three kinds of vessels. We have arteries, and they lead to arterioles. IOLES means what? Right, small. So the arterioles are small arteries. They go to the capillaries. If you were British, you'd call them capillaries. The capillaries, and up to this point, the vascular system sort of looks like a tree. You start out with large diameter arteries, like the aorta would be the largest, and that would be like the trunk of the tree, and then as it branches into other arteries, and those in turn branch into arterioles, the diameter of those vessels decreases, sort of like the change in vessel the diameter of the limbs in a tree. Capillaries would be way out at the end. That would be where the leaves would be, and those capillaries are tiny, microscopic. Okay. Then coming back, we have sort of the reverse trend. We start with really small, and then they get gradually larger and larger and larger. Capillaries drain into the venules, which means little veins, and then venules drain into the veins. So here is a drawing to show you the changes in diameter, and not only is it showing you that, but it's also showing you something about the oxygen levels. So this would be blood vessels in the systemic side of the circulatory system. We start out with red for oxygen rich. Blood gets to the arterioles, it's still oxygen rich, goes into the capillaries, and here is where we see the oxygen being released and carbon dioxide being picked up. And I use purple which is red and blue mixed together, the blood in the capillaries are going to be somewhere between oxygen rich and oxygen deficient. Actually, as the blood enters the capillary, it would be rich. So the top of these capillaries should be red. The purple should be in the middle. And then by the time the blood is leaving the capillaries, the oxygen is gone. This is going to be blue at this end. So it should be a fade from red to purple to blue, and then into the venule, and then into the vein. Okay, so the vessels have 4 functions. One is to transport blood and the contents of the blood, obviously. It's a distribution system. One is to provide for exchange with the surrounding structures and fluids. That's going to be the capillaries that do that. It's going to help us regulate blood pressure. Remember, I told you that when the heart relaxes, the blood vessels are constricting against the blood that they have inside of them, and this keeps the pressure from dropping to 0. And then they're going to direct the blood flow out to the cells as required. We're going to see that depending on the needs of the various areas within the body, some blood vessels may dilate and others may constrict during the cardiac cycle, so that the blood gets directed into the areas that are going to be the most needy. So arteries. Arteries going to transport blood from the chambers of the heart. Notice chambers is bold, underlined, and blue. That's just to draw attention to this. So the aorta carries blood away from the heart chambers. So do the coronary arteries, but the coronary arteries bring blood to the walls of the heart, not the chambers of the heart. The arteries tend to be thick-walled, and so just as a curiosity, Pansy, do you know which one would be the thickest of all?
Huh?
Right, the aorta. Hey, she knows everything. Okay, so the tunica intima is going to be on the inside, adjacent to the lumen. Then we have the tunica media, and then we have the tunica externa. Tunica externa is on the outside. Tunica means coat, so that's what's being referenced here. So here's a diagram of a blood vessel that's been transected. We have the tunica externa on the outside. We have the tunica media. Now the tunica media is going to vary in thickness. Average artery is going to be about 40 cells or so thick. The thickest one of all would be the aorta, which is about 200 cells thick. In a arterial, the tunica media is going to be about 8 cells thick. And the capillaries, it's 0. There is no muscle tissue in the capillaries. And then in the venules and the veins are going to be about the same, 2 to 3 cells, muscle cells thick. We have the elastic and white fibrous tissue layer that's going to surround the lumen, and it's going to be deep to the tunica media. This helps reduce the risk of rupture. It allows for stretch and return to original shape. The tunica intima or tunica interna is going to be endothelial cells, squamous cells that are smooth to reduce friction, and then we have the lumen through which the blood passes. Okay, so tunica intima, endothelial layer with basement membrane. Tunica media, mostly smooth muscle tissue. There are some elastic fibers in there. This is going to keep the blood moving even when the heart isn't contracting, because when the vessels stretch, they contract against that stretching. When the heart relaxes, they keep the blood going. Okay. Tunica externa is going to include connective tissue, elastic and collagen fibers. The elastic is going to allow for pliability and passive return to original shape. Collagen fibers are going to help prevent the overdistension and perhaps rupture of a vessel. And then we're going to have, especially in the arteries, because of their thick walls, we're going to have a vasa vasorum. The vasa vasorum is going to be a blood supply to the walls of the thicker vessels. So here's a large vessel. It's a branch of the it could be the branch off the aorta, or it could be the aorta itself for that matter. You can see the big thick walls here, so it's an artery. And then we have these smaller vessels coming into that wall, bringing in oxygen-rich blood from a vessel that's adjacent to the large vessel. If we have blood going in, we're going to need to have what? Right, blood has to come out. So there are going to be other vessels that allow this blood to leave the walls of the larger vessel. Arterioles. Arterioles are going to have thinner walls than the arteries. As I mentioned, average arteriole might have 8 muscle cells thick. They turn out to be really important because if we decrease the diameter of an arteriole in an area, it reduces the blood flow into that area, and this gives us a way of controlling where we send the blood in the circulatory system. Then if we relax those muscles, it increases the diameter and more blood goes into the area. So we can actually, although the heart is just blindly pumping this blood out, these arterioles allow us to direct the blood flow into the areas that need it most and reduce the blood flow into the areas that need it least. And we already said that that's necessary because we don't have enough blood to send it everywhere all the time. Okay. The diameter is going to be controlled by the autonomic nervous system, and as I mentioned, it's going to help regulate blood pressure. If you have constriction of the arterioles in general, the pressure will go up. If we have relaxation, the pressure will drop. And this is one way during hemorrhaging that we can help prevent the blood pressure from dropping too low. If the blood pressure drops too low, the cardiovascular system will fail and the person will die. So you don't want that, obviously. Okay, capillaries. Capillaries are going to be formed by 1 or 2 epithelial cells connected together by tight junctions, and they sort of rolled up like enchilada or a yum chow or a cannoli. The diameter of the lumen is about the size of a red blood cell. It's a pretty tight fit, actually. So here we have a single cell forming a capillary, and here we have 2 cells coming together to form a capillary. And the blood would go through this lumen. Capillaries are very numerous. In fact, incredibly numerous. It's kind of mind-boggling to see the numbers. And the combined surface area for the capillaries is 6,300 square meters. This is an enormous surface area, and you get this large area because of miniaturization. Remember, the principle of miniaturization is if you make things small, you increase the surface area to volume ratio, and we want a high surface area so that exchange can occur between the blood and the surrounding tissues. And we find that normally no living cell is going to be further than 2 or 3 cell diameters from a functional capillary. If it gets much more than that, they start to suffer from the inability of the system to provide for their needs. Okay. So, there are precapillary sphincters. Precapillary sphincters are going to allow us to divert blood through the capillary beds or from the capillary beds if they're not in use. And then the way it's been suggested that these may work is that when they have adequate amounts of oxygen, they close down, and that diverts blood into areas that need the oxygen more. But then when they start to fatigue, because their oxygen levels are dropping, then they relax and the blood goes into that area because the oxygen levels are dropping. So this is kind of a neat and simple way of directing blood into areas that need the blood the most. Some capillary beds are going to have a shunt to bypass the capillary bed, and that just goes the blood going directly from arterioles to venules. Now, we don't open all the capillary beds up all at the same time, and this is really important. Why? Right, we don't have enough blood to supply every place at the same time. So if all of them opened up, the blood pressure would drop too much, and it wouldn't be an effective use of our circulatory system. If you think about this, this is a little bit like the fire hydrants in a city. If somebody were to go around and open up all the fire hydrants, the water pressure would drop so much that none of the fire hydrants would be effective in fighting fires because the water pressure would be too low. So that gets us to the end of part 1. This is going to be the first Camtasia. We'll make a second Camtasia at another time after Pansy recuperates. She needs a new meal and some water to recover from all this work that she's been doing. So I hope you've enjoyed this. I hope that you get some good information out of it to help you be successful with this portion of the course. Have a great day, guys. Actually, have a spectacular day.